right, guys, I am going to just record the remainder of safety that we talked about last week. We did run out of time and we have a lot of information to go over tonight. So I just decided to go ahead and record just the last little bit of slides. I'll post this on YouTube for you and then post the link on Brightspace. And you guys can take a look at this at your leisure. But this material will be on exam 1, which is next week. So when we think about different organizations that promote safe patient care. We know the American Nurses Association, they have a big input on recommending different public safety changes. And then we know all about QSIN. We've talked about that several times, quality and safety education for nurses. They have a big task force that's used to develop, they look at various educational pieces, and they were able to identify 6 competencies that all nursing students should have by graduation. And we've talked about a few of them throughout this semester already. We know that safety, by definition, is any attempt to minimize the risk of harm to patients and providers. So not only are we keeping our patients safe, but we are also keeping ourselves safe. So if we don't keep ourselves safe and prevent injuries, then we won't be able to give that quality, effective care to our patients. So we want to minimize the risk of harm to patients and providers through both system effectiveness and individual performance, which basically means that the systems that we work under for these facilities, they have to have plan of actions, right? They have to develop policies and procedures that they know work to keep employees safe. And then we have to strive in our own individual performance to know what these policies and procedures are and to bring that into our scope of practice when we're caring for patients. So in 2015, there were national patient safety goals that were developed for hospitals. One of the big ones was to be able to identify our patients correctly. And we talk so much about this. So we always want to use at least 2 ways to identify our patients. So we know what we always talk about in lab and in classroom. Tell me your name and date of birth. We do this to make sure that each patient gets the correct medication and treatment. And we make sure that the correct patient gets the correct blood when they get a blood transfusion. So we're always going to identify that patient. We're always going to scan that badge when we're giving medications. These are not areas where we will ever take a shortcut, because that's when injuries and medication errors will happen. Another safety goal that they developed was to improve staff communication. So get important test results to the right staff person on time. So we know how important that interpersonal communication is. We are just one little aspect of patient care. It's us, it's the doctors, it's speech pathology, it's physical therapy, occupational therapy, radiology, case managers, social workers. We all have a very intricate piece of the puzzle, which develops to giving that safe care to our patients. Use medicine safely. So before a procedure, we make sure if we reconstitute anything that we label all of our medications appropriately, and we take extra care with patients who take medications to thin their blood. For example, we want to make sure that they are, listed as a high fall risk if they are a high fall risk. And if they are, they should have non-skid socks on. They should have a red armband. They should have a fall sign on the door. They should have bed alarm and chair alarms on. We also want to prevent any unintentional bleeding. So when we're removing IVs or after lab draws, we make sure that we hold pressure on that extremity to make sure that they don't lose any blood. We want to make sure that we're telling our patients to use them soft bristled toothbrushes so that it doesn't make their gums bleed. We want to make sure that if they are shaving in the hospital, they never use a regular disposable razor, because that can cause them to cut their skin. We only want to promote the use of electronic razors. We want to be able to use medication safely. So we want to record and pass along correct information about a patient's medication. So these are things that we would talk about in bedside report that would be important for us to let the other nurse know. We want to find out what medicines the patient is taking, and we want to compare those medications to new medications that are going to be given to the patient, so we can educate them and let them know about these new medications and make sure they have what they need for when they go home to be successful. Make sure the patient knows which medications to take when they're at home. So this would all be included in those discharge instructions, and we would go under We would go over medications all at one time. And sometimes our patients may say, oh, my wife handles all that, let her take care of that. Well, we certainly would want to pick up from that comment that the wife is very involved in the patient's care, but we also want the patient to be accountable for their own care as well. So what we would say is, that's great. We would love to let your wife know when she comes, let us know, and we'll teach both of you about your medications. And then we want to tell the patient it's important to bring their up-to-date list of medications every time they go to the doctor. So that way we have the same list and we're not missing anything. We want to use alarms safely. So make improvements to ensure that alarms on medical equipment are heard and responded to on time. So for our cardiac monitors, we want to make sure that those alarms are set and on those computers at each nurse's station so we can hear if there's an alarm that goes off. Bed alarms, chair alarms should be set and activated. Same thing with our IV pumps. Make sure that those volumes are turned up so that we hear them. And we also kind of have to think of kind of like the mentality that every patient is my patient. So if you're walking past a room or you're in a corridor where there's 5 or 6 rooms together and you hear a bed alarm or going off, or you hear a telemetry monitor going off, or you hear an IV pole pumping, it is good for you to go ahead and respond to that patient, especially if it's a bed alarm, because we have to make sure that that patient is not falling. And if you're by that room, then we want you to stop and take care of that patient. We want you to do for that patient what you would want someone to do for your family or loved one. We wouldn't want to say, oh, well, the nurse isn't here, it's her problem, let her deal with it. We never want to have that type of mentality in nursing. And of course, we know we have to prevent infection, right? We have to know how to break the chains of infection. And we know that that is hand hygiene is the #1 way to break the chain of infection. The CDC did report a couple years ago that almost 2 million patients will get hospital-acquired infections. Of those 2 million, 90,000 of them will die. We have to use the hand cleaning guidelines from the Centers for Disease Control and Prevention or the World Health Organization. We want to set goals for improving hand hygiene and use those goals to improve hand hygiene. So these are things that you would see in the hospital level. They would be setting these goals. More on preventing infection. Use proven guidelines, evidence-based practice to prevent infections that are difficult to treat. So remember, back to, we talked about this in infection control. We don't give antibiotics for viruses because they don't work. We know that if we give antibiotics for things that aren't going to be treated, that we're going to develop those bacteria-resistant infections that we're not going to be able to treat. We want to use proven guidelines, evidence-based practice to prevent infection from blood, infection of the blood from central lines. So make sure we're using medical asepsis and sterile technique when we're caring for these lines. Use proven guidelines to prevent infections after surgery. So monitoring the site for infection, getting the patient up early and having them ambulate, making sure they're using their incentive spirometer so they don't get pneumonia. And use those proven guidelines to prevent infections of the urinary tract that are caused by catheters. So remember, we talked about those nurse-driven protocols that we have into place that we can evaluate that patient to see if they're able to ambulate on their own now. Are they able to get up and go to the bathroom? Do they need these catheters? And then never ever putting catheters in for reasons that aren't warranted. Identify patients with safety risks, find out which patients are most likely to try and commit suicide. So when a patient is admitted into the hospital, there are certain questions that are inside of a navigator database that you would be asking your questions, that you would be asking your patient that includes certain questions of, do they have a history of suicide attempts? Do they have any thoughts about harming themselves or anyone else? And then we want to prevent mistakes in surgery. Make sure that the correct surgery is done on the correct patient and at the correct place on the patient's body. Make sure that the correct place on the patient's body where the surgery is going to be done is marked. That's usually done by the doctor. And then once the patient gets in the OR, we have this timeout, which is this pause where everybody stops before the surgery to make sure that a mistake is not being made. So they're going to talk about the patient. What's the patient's name, the date of birth? What's the patient having done? What side of the body? Is that body part marked? And then we want to improve the effectiveness of caregiving communication, because we know that some things can be miscommunicated as things go down the line from person to person. So when we're getting orders from a doctor, we want to make sure that we do that read back. So if the doctor orders, 100 ml, 100 ml of normal saline per hour, we want to say, okay, I heard you say that you want Mrs. Jones to have normal saline to run at 100 mLs per hour. Is that correct? Any type of verbal or telephone order must be verified. So we want to write down that order. We want to read that information back to the person that gave it to us. And then we want to have them confirm that what you read back was correct. We always want to make sure that we are avoiding using those abbreviations that are not recognized in nursing and in the medical field. And we don't want to use any acronyms that are not appropriate. And we talked about never events. So never events are healthcare acquired complications for which Medicare will no longer reimburse institutions. So these are things that should never happen, which means they're preventable. And we have a big part in preventing them. So severe pressure ulcers. So again, looking at our patients, recognizing, are they able to get up? Are they staying in bed too long? Do we have to reposition them? Are they incontinent? Do we have to protect their skin? Preventing falls and trauma, preventing those infections that are associated with urinary catheters and IV catheters, and then surgical site infections following certain elective procedures. Sentinel events are unexplained occurrences involving death or serious physical or psychological injury or the risk of death or injury. That's definition by the Joint Commission. These are things that we never, ever, ever want to happen. Other safety interventions that we can use, we're always going to use good infection control measures. We're going to follow our policy and procedures. If we're ever not sure exactly what type of interventions we would use, we can always go back and look at what the CDC, the Center for Disease Control, recommends, and we can also compare it to what we have in our policies and our procedures. Always follow hand washing guidelines. Always be prepared to do CPR. Know your facility's fire and emergency plans. And we know our when we talk about fire plans, we talk about RACE. So the R is rescue anyone that's in immediate danger, not just your patients, but any patients. We sound that alarm, we activate that fire code system, and we notify the appropriate personnel. C, we want to confine, make sure we close all the doors and windows to prevent the fire from spreading. And then E would be extinguish. And then some emergency preparedness information. So for a disaster, disasters are a tragic event of great magnitude that require the response of many, many people outside the involved community. So terror attacks, things like that, or if we think of tornadoes, hurricanes, things like that. Natural disasters also are included in that, floods, man-made disasters, so toxic spills, war, terrorist activity. Bioterrorism, this is the deliberate spread of any type of pathogenic organism into that outlying community with an attempt to cause widespread illness, fear, and panic. Chemical terrorism involves the deliberate release of any type of a chemical compound that has the potential of harming people. Nuclear terrorism is intentional introduction of any type of radioactive material into the environment, again, for that purpose of causing injury and death. And then cyber terror involves involves the use of high technology to disable or delete critical infrastructure, data, or information. And I think that pretty much sums up what we were talking about for safety. So you can watch this video on YouTube, and I will post the link on Brightspace. Have a good day.